Good afternoon, ladies and gentlemen. On behalf of the South African Medical Association, as well as SADC Healthcare Workers Network, I'd like to thank you for joining us this evening to discuss a crucial and often overlooked issue in the medical field, namely the experience of grief and the loss of patients and the profound impact that this can have on medical practitioners. Our gathering here underscores the urgency of addressing this matter to ensure the well being of our healthcare professionals and the quality of patient care. As healthcare providers, we are trained to save lives, alleviate suffering, and provide the best possible care to those entrusted to us. However, it is a harsh reality that despite our best efforts, we sometimes face the profound sorrow of losing patients we have dedicated our time and expertise to. The emotional weight that comes with the loss of a patient is something that we must confront, acknowledge, and address. Grief is not the sign of weakness, but rather a testament to our compassion, dedication, and the deep connection we form with our patients and their families. It is a natural response to the emotional challenges we face daily as we navigate the intricate world of healthcare. Today, we will explore this complex aspect of our profession, recognizing that it is crucial to acknowledge and understand the multifaceted nature of grief. We will discuss the ways in which we as doctors can cope with our own feelings of loss and provide the support that our colleagues may require. As I come in front of you, colleagues, I'm humbled to be able to introduce our next speaker. I am Dr. Zanele Bigicha. I'm also a board member of the South African Medical Association. And I'm glad to say that we are having this conversation just as we are coming out of what is known as Mental Health Month in October, where we did put a focus as South Africa on issues around mental health, particularly coming out of COVID, where we've noticed the impact that it has on our practitioners. I now find it my greatest pleasure to introduce our first speaker, which is Dr. Asanga Fernando, who will provide a comprehensive exploration of how doctors can effectively deal with death, both in the context of losing a patient and personal loss. Dr. Fernando is a consultant cancer liaison psychiatrist and has a number of clinical learnerships, research, and educational roles in cancer and psychiatry at one of the biggest teaching hospitals and medical schools in the United Kingdom. He is also a clinical director for simulation and technology enhancing learning across the trust and medical school, and has an active research portfolio encompassing mental health, oncology, palliative care, patient safety, digital health, and human factors. He is an honorary senior lecturer specializing in clinical pharmacology and has a strong interest in global mental health policy. From this bio, I think you can see that he's going to give us a very interesting perspective on this topic. So, as I would like to introduce him to you, Dr. Fernando, over to you.
Hi, thank you very much for that really kind and lengthy introduction. I gather you can hear me all right. Before I start, I was going to say we're actually going to do this discussion and presentation together. I'm joined by my colleague, Dr. Joe Ashcroft, who is a consultant clinical psychologist working with me and our team lead. And we work together as part of a cancer psychological support team here in London's biggest teaching hospital for cancer patients, so to support their psychological well-being. And we work as part of a team of how many people?
10.
10. So I think it's London's largest psychological support team, fully embedded within cancer and oncology. So it's great to be here. And thank you very much for the invite. And I hope what both Joe and I say over the next few minutes will be useful to you. So thank you very much. Okay, so I'm now going to attempt to share my screen. Okay, so you should all be seeing my first slide, and I'll expect someone to tell me if that's not the case.
We can see it.
Yes,
Thank
we
you.
can see
Brilliant,
you.
lovely. So I'm just going to jump on, and I guess the other thing to say right at the outset is very happy to be contacted by any of you. I know that we'll sort of signpost a couple of resources at the end, but also quite happy to be an email contact as well. So, right, okay. Oh, right, sorry, there we go, right. Okay, so what we're going to talk about for the next few minutes is really, how doctors can effectively deal with death. We're going to discuss whether there is such a thing as a normal reaction to death. And I guess differentiating a little bit, Joe is going to help us to understand sort of, why it's important, I guess, to differentiate a little bit between the loss of a patient and how that's different to experiencing the death of a loved one. We're going to talk a little bit about what happens if we don't deal with death effectively, and then finish up on a little bit about what we can do differently. And I'm aware that the ground is probably very, very different in South Africa in terms of culture, in terms of where service provision lies, in terms of sort of the basis for change. But just to before I hand over to Joe, just to tap into what was said earlier, I think actually we recognize now post-COVID especially the importance of mental health, but also crucially as a profession for doctors, just really how important it is to talk up about these things and speak openly about many of these issues that haven't been discussed to date, and also how these issues have a real legitimate and lasting impact on the mental health and well-being of practitioners. So that said, it's my great privilege to hand you over to my colleague, Dr. Jo Ashcroft.
Thank you very much. Well, I hope that some of the points that I'm going to cover are just going to be useful for us to then have an opportunity to do a bit of reflecting and thinking about your particular circumstances and your practice. So I hope these are just some pointers that can be useful for us to reflect on later in the session. And just to give you a little bit of context in terms of my background, I'm obviously conscious I'm here as a psychologist rather than a medic, but spent a great deal of my time working in acute medical settings. And a big part of our role in our team is about teaching, training and supporting the healthcare professionals that we work with. I also bring personal experience, as I think probably all of you will have personal experience that you bring to the role. So I think part of the conversation that I'm going to have today is how to manage and harness those experiences in a way that enables you to do your job effectively, but also enables you to look after yourself as a human and as an individual. So we want to start off thinking a little bit about what a normal response is when we experience the death of a patient. Now, it won't be a surprise to you that I'm going to say there's going to be a whole range of different thoughts, feelings and experiences that you'll go through, and that will depend on the circumstances of the death. That will depend on the circumstances you find yourself in and the range of your own experiences that you bring to those moments. So for some folks, there's going to be a real understandable apprehension about what end of care will be like. And even though we're immersed in this setting where death and dying happens a lot, your first experiencing that, of witnessing that on a human level, is going to bring about a whole range of feelings. You might also notice that you were thinking more about past bereavements, or your own personal experiences or bereavements that you've witnessed prior to this. And certainly that will evoke emotions in you that you've experienced in the past. For me personally, that is always the case. I always bring my own personal experience of loss of loved ones that I have witnessed, but also those deaths that I've been privileged to be part of within my role in healthcare. I think it's fair and obvious to say that you may well also have fears about your own death when facing these kind of clinical scenarios. It's a unique position that we're in as healthcare providers, but often day to day as human beings, we don't always necessarily in our everyday job face our mortality or existential situations. So I think a lot of that will show up for people. You may also have some anxiety about the experiences and reactions you have to a death and how long you may continue to experience those. For some people, it might be a worry that that was fleeting, and you may be concerned that maybe I should have had more of a reaction to that, or in other circumstances, it might be that those feelings stay with you for quite some time. And again, it won't surprise you to know that those are very normal reactions at either end of that spectrum. And the death of anybody that you witness is going to leave you with a whole range of emotions. And we know this from bereavement and grief work. There's going to be feelings of numbness, distress, despair, sadness, worry, anxiety, and those can chop and change. They can be short-lived, they can last for longer. So that's part of a normal kind of bereavement reaction that we would expect to see. And it's going to be hard to feel compassion and containment all of the time when death is something that you're witnessing in your working environment day to day. That doesn't mean that you as a healthcare professional do not care or don't have compassion, but there are some times where we have to evoke our means of coping with day-to-day burdens and stresses that feel overwhelming. And what I would say is sort of numbness or lack of emotions can often be, exhaustion. It's as I've said, your mind's way of coping with what can feel quite overwhelming at the time. So it's about being gentle with yourself and acknowledging that that's part and parcel and nothing for you to feel anything negative about. So I think it's just a point that all of these are very normal reactions. And actually, I'd probably be more concerned if you didn't have any responses or feelings or thoughts about death and dying before, during, or after that experience. So just thinking about the time when a patient dies, there isn't really a right or wrong way to acknowledge an individual's death, but I think it's actually, as Sangha was saying, it's really important to create a small, even if it's a small amount of space within your busy working day, to allow yourself to acknowledge a death. And even actually, I think before a death. So certainly there's several cases that stick with me, and one in particular where I was invited into some very intimate moments prior to death. So this patient didn't die for another 2-3 days, but they were very emotional conversations and they were very intimate moments. And I noticed that I was significantly affected by those, and I was about to rush off onto my next kind of patients on the ward, but I needed to stop. I needed to come back. I needed to give myself that little bit of space to reflect on the enormity of what I'd witnessed. What I would say is it can be helpful, it's very individual, but to do something potentially to mark an individual's death. And for some people, those rituals are very different. That might be that you, so for some people, they might light a candle, or they might put a particular object or picture in their workspace, or they may take a moment at a particular time in the day just to think about that person, just as a means of kind of acknowledging their passing. And I think it can also be helpful. We as clinicians can be inordinately hard on ourselves and strive to do better. So we can often focus on things that don't go well, which is important. But I think it's always really useful to think as well about what aspects of end-of-life care went well, and what we hope to replicate and what we've taken away from that. And I would also say it's really important to talk to other people. We do that as a cancer psychological support team, but that's embedded in what we do. So what we also try and teach and embed within the teams that we support are those moments to share as a team, your experiences of that patient, your experiences of that loss. And actually, I was talking to a colleague of mine, a psychologist who works in our palliative care service, and they are still working as a team, and they work with, that is what they do, death and dying. They are still thinking about how they mark and reflect on patient deaths, and moving away from that being a kind of tick box, let's go through what went well, what didn't, and bringing more of that emotional psychological perspective. And I do think it's also important that we acknowledge where we are struggling, and that it's important that you can talk to colleagues. I don't know what support structures are in place for yourselves through your healthcare providers and your work settings, but if there's an opportunity to kind of engage in any care through those, if that's needed, that's really important. And the obvious goes to talking to friends and families and having that opportunity to debrief. And we just wanted to think a little bit about self-care at the end of life, because what we witness is enormous. And I think there's something in our society where we don't talk about death and dying. We talk a lot about birth and entering into life and all the wonders, yet the traumas of that, but we don't often make time to think about the enormity of death. And I think there's an awful lot of self-care that we could be doing, because we often feel underprepared and that we're often left with difficult experiences. And as healthcare professionals, we can kind of push those under the carpet a bit and move on to the next. So it's really important to sort of think about, what are your indicators that actually things are starting to mount up and get on top of you? So these are just a few kind of key headers in terms of some of the terminology that we might hear. So we might think about chronic stress. So by that, we mean a kind of state of worry, mental tension caused by a difficult situation. And stress is that normal human response or reaction that prompts us to address challenges or difficulties. And it's important, but the way we respond to stress and ongoing stress can have a huge impact on our emotional well-being. So we're looking out for constant sources of stress and what the impact might be. Now, I don't know, there's another term that we often use called burnout. And by that, we mean feeling very overwhelmed, exhausted as a result of almost constant workplace pressures. So, I think facing these sorts of what I imagine are going to be both positive and rewarding, but also hugely emotional and traumatic experiences is going to have a really big impact. So it's really looking out for what we would consider much more of a clinical condition, where people are starting to feel that exhaustion, that emotional detachment, and that lack of achievement. So it's the chronicity and the severity of that that's important to keep an eye on. And I do mention post-traumatic stress. So you guys will witness very difficult and traumatic deaths by the nature of your work. And we know a little bit that there's going to be some normal post-traumatic stress reactions that we would anticipate would resolve within a relatively short space of time. But it's important to acknowledge that actually, if you have experienced or witnessed something very difficult, that if symptoms of trauma are persisting, so those might be irritability, flashbacks, finding it very difficult to concentrate, thinking back to the experiences. So it's looking out for those, and if they're persistent, that's something that we really need to pay attention to and that we need to do something with. So I want to think a little bit about kind of self-care, as mentioned at End of Care, and things that you can start doing to kind of preemptively look after your emotional well-being. So as I mentioned, it's so important that we try, and I think this is, Asanga's maybe going to touch on this a bit later, that we sort of as a system allow for these moments. I think there's an enormity of pressure that we're under as healthcare professionals to continue to see patient after patient after patient, and we appreciate there are real logistics around that, but I think there's a culture shift in allowing some small spaces within our clinical time in a clinical area where we can pause, stop. Even I would talk about grounding. So for me, even if that's just allowing myself 20 seconds to stop quietly, press my feet into the floor, take 10 deep breaths, just notice a little bit about my surroundings, that's enough to just steady myself and give myself a small pause to then be able to think, okay, well, what do I need to be doing? What's most useful for me in this next moment? Trying to maintain some sort of routine during your day can help you feel more in control if you're feeling a bit swept away by different things. I mean, it goes without saying, but this is the stuff that gets missed, is looking after your basic needs. We had a trainee clinical psychologist who is with us, who sat in on a clinic within our colorectal team, which was breaking bad news after breaking bad news after breaking bad news. And the medic doing that just took no break. There was no time to eat. There was no time to pause. There was no time to reflect. So I think that shifts really need to happen with that. And I think when we're facing death and dying and the enormity of that, which I will keep emphasizing, I think having these small moments to kind of self-care, to eat, to take a break, to be able to get some sleep, and using all sorts of wonderful resources and apps and things that are out there to support with that. Creating peer support networks. So I don't know if you're in WhatsApp groups with your teams or outside of work, but just some means of being able to communicate with your team when you're feeling overwhelmed. And a lot during COVID, we talked about huddles, so having moments with your team at the end of the day to just do a small amount of reflection, but also a little bit of self-care, so how you can leave work here and what you're going to do when you step outside of the hospital setting. Staying connected with family and friends as an ability to kind of decompress and focus on life outside of work. I always say look out for, if you're doing things to look after yourself outside of work, that you're not then doing something that puts you in a caring role outside of that setting. Trying to get some exercise, looking after yourself in those ways. And this is not an exhaustive list, this is just to prompt you and thinking about what for you, what are your unique ways that you know are restorative to you, or that stop you from getting to the point where you're starting to feel overwhelmed. I think there's a bit of a continuation on from that, so it's really important to just schedule these sorts of things in, and just be ready and open for difficulty. You're going to feel difficult experiences, as are your colleagues. So kind of creating that openness to have those conversations and those experiences. And we've sort of talked a little bit about this, but sort of gestures for yourself in terms of self-care. So I know that food is my go-to, and that's the first thing that I will do in a moment of self-care. But yeah, think about things that, again, you find restorative and comforting. And I just want to, self-compassion in itself is quite a big idea and quite a big topic, so I'm not going to go into that in loads of detail, but it's this idea of treating ourselves, talking to ourselves in a way that we would wish to be talked to by someone else, and we're not very good at that. And I think in the healthcare profession, we have very high unrelenting standards that we experience externally onto ourselves and that we also place on ourselves. So it's just trying to take a moment to be encouraging of, thoughtful of yourself. So engaging in some positive self-talk. So avoiding that critical voice, or if you are noticing that coming in, just saying to yourself, okay, hang on, what is more helpful for me to say to myself here? What would I be saying to a colleague? What would I be saying to someone who's been through this difficult experience and was sharing that with me? Looking out for kind of maybe what might be your patterns. Are you someone who tends to blame yourself, or, as we say, be critical, should have done better? There is scope for learning, but it's also avoiding that sort of berating yourself and exacerbating difficult experiences and feelings. And just starting to notice if negativity, self-criticism, self-doubt, if all of these things are creeping in and taking over, that might be an indicator that you're feeling overwhelmed and some extra support's required. And however you do that just might be having that small little conversation in your head. That might be jotting something down, whatever works for you, really. And you might find experiences of death and dying leave you reflecting on those. So that might be things that you're remembering from those scenarios that are going around your head a lot, or they might be kind of future worries for things that are coming up. Am I going to be in that situation again, or what does that mean in terms of my personal experience, and has that triggered something in me? So good to talk about that, but if you're finding they're quite repetitive and you're just needing to step out from those or have a break from those, and engaging in some mindfulness and some relaxation can be really helpful. And I guess just a nod back to some of those trauma symptoms. I think having these debriefs, talking about these experiences, is crucial to enable you to start that natural process of assimilating the experience. So really sharing your stories, your experiences, as I've mentioned, doing that grounding, giving yourself that moment to connect, and that I'm here in this moment, not in the moment that I was in. Being quite in your body, physical activity and movement as well can kind of help us with that, engaging in some breathing exercises. And certainly if folks find it helpful, there's various resources and ideas that I can certainly happily share with you and send that out. And sometimes some facilitated debriefs. So certainly in very complex or difficult deaths, that's something that we would do either as a team if it was connected to the services that we work with, or we have a wider staff support team that would support staff across the trust. So sometimes having that structured specific environment to talk about a particular death can be helpful. I don't know in South Africa, but we do Schwartz rounds here within the trust. So they're a real reflective space that moves away from problem solving. And actually we had one recently that was on the theme of can't get you out of my head. We had 4 people on the panel, and very interestingly, all of us talked about death and dying. Both positive and negative experiences, and none of the rest of the panel knew that the focus for each of us was going to be on the experience of a death of a patient. So having these sorts of environments, and it also creates that positive culture that needs to be there, I think. So overall, I think, it's keeping an eye on you, knowing what your triggers are, knowing what your signs and symptoms are, knowing that they're going to be normal, difficult thoughts, feelings and experiences you're going to go through, and those are to be expected, but just stay attuned to yourself. And I think it's creating these rituals, these spaces, the self-care. And I also think, again, Asanga's going to cover this, it's also supporting you guys in understanding what clinical scenarios you're going to walk into, and feeling some level of training, skill, equipment to know about how to have these difficult conversations, or what you might do in these clinical scenarios, so as best we can prepare you so that you're not as taken aback. But yeah, those would be my thoughts. And I think, you're going to know your indicators, you're going to know your threshold. So when actually things are getting overwhelming, they're getting intense, things are significantly impacting on day-to-day functioning, sleep, appetite, that you're noticing these sorts of things, that you're disconnected, you're demotivated, you're not enjoying the things you were enjoying. I think it's really important to acknowledge that's probably a time when you are reaching your threshold, and it's important to access some more help and support, because talking about chronic stress, talking about burnout, it's pushing through those consistently is going to be to your detriment, and is not going to help you doing the role that you do. So I'm going to hand over now to Asanga.
Okay.
Talk a little bit more.
Brilliant. Thanks, Jo. Yeah, I just thought it was really important for Jo to share that. And I think, as I'm really glad that she did, because I think as medics, we often lack those insights and lack the patience, I think, to understand why those measures are so important. And look, just very quickly, talking about some of the things that Jo sort of alluded to, I think it's important to point out that dealing with the death of patients can obviously have a massive mental health impact on all of us, on us as medics. And I think actually, that mental health experience can, be the full gamut of mental health experiences, from sort of, anxiety, depression, through to sort of, almost, depersonalization, derealization, frankly, suicidal behavior, and post-traumatic stress disorder. And I think it's a really important point to say that actually, we don't recognize these nearly enough. And I think actually that's why, it's really important that we realize we've just come out of COVID, where people have lost their usual sort of coping strategies at a time, when others may have wanted to go to the pub, hang out with their friends. And, I think everyone understood the impact of mental health on our daily functioning. And I think it's an important lesson that we sort of recognize that where healthcare practitioners see these things day in, day out, there is a real risk of these things happening. And I think one thing Jo was talking about was the Schwartz round. And one thing about that was very powerfully that you had the medical director of the trust and several members of the exec talking very openly about experiences of death and dying, patients that they'd seen, and how it had affected them. And I think, we talk about systems change and things like that, and such a hugely important and influential aspect of that is role modeling as well. So where there's a willingness to change, and Jo had a slide earlier about, we are all made of stories. And I think, when you look you know, when you look at where doctors want to work, when you look at high-performing organizations, it's generally the ones where people feel valued and feel looked after. Certainly here we have an NHS staff survey, and generally the organizations that come top of that are the ones that value their workforce. And when I listen to junior doctors talking about where they want to work next, you know, it's stories that sell more than a glossy brochure. It's what people know is what's happening on the ground. And really there is something to be said there about that role modeling in terms of sort of culture change. But talking about the mental health side of things, I think we do need to think about a sort of range of interventions, and Joe's already sort of alluded to sort of staff support. I mean, I know here in the UK we have that, but we also have, you know, specialist support measures for doctors, so practitioner, healthcare practitioner programs, helplines that are sort of funded specifically for doctors in a destigmatizing and normalizing way. And what's pretty powerful is hearing senior people talk about the need that they've had for help. So I think actually that is hugely important, but recognizing that actually these things, you know, take, you know, for mental health, it's taken COVID for people to be able to talk more openly about those things. And it's important to recognize in this arena, talking about death and dying, that's no different. And Joe also alluded to sort of peer support networks. I mean, you know, that's hugely important. And I think, you know, it's something that if your profession recognizes that. So for instance, as a psychiatrist within the Royal College, we have all our CPD in terms of CPD groups, but an important function of that, it also is sort of peer support. And I think that's been really, really helpful. And then just before I finish up and talk about a few other things, I guess, you know, distinguishing between the mindset of being a doctor, wanting to be solution focused with patients, and then also caring for a loved one who's dying. I think it's important to sort of recognize actually the distress and the difficulty some of us have as doctors in terms of sort of having to hang up that medical scaffold and that medical knowledge and to think about sort of things, whether it be survival curves or data, and recognize that actually, you know, how do we think about being there for a loved one in a manner that they need and not in a manner that we want to sort of impose on that. And managing that uncertainty can be difficult. And I think it's just important to sort of, you know, leave that with you. You know, people have different ways of going through that, but it's certainly a tension that I think people who recognize those two processes really understand. And so just very quickly to sort of end on a couple of other things. I mean, I've got the strapline there, no health without mental health. And that was obviously the motto of our Royal College for a long period of time. The reason I'm saying that is, you know, it's true of all of us as human beings. The evidence is very clear in that case. I'm a psychiatrist who's chosen to work within oncology and cancer, you know, and working very closely with my colleagues here in an environment that we are fully embedded within the acute trust. We're not employed by mental health, we're employed by oncology and cancer. And that's hugely important, destigmatizing for patients as well. Very quickly, I think, so integration is hugely important when you're thinking about mental health and destigmatizing it. And again, when we're talking about attitudes to death and dying as well, our team covers palliative care. And it just, you know, there aren't too many psychiatrists here in the UK, and I appreciate it's different in South Africa, but too many psychiatrists and psychological support services that are embedded within oncology specifically. And I think actually when we think about integration, when we think about what's important to our patients, it's really just thinking about, you know, you're not just based on the same site, but you do joint clinics, you think about quality of life improvements, and you think about integrating beyond the clinical as well. And again, happy to talk to you all about sort of how we've done that here. And again, for those of you who are physicians, the Royal College of Physicians in London published a whole series of mental health related articles this last month. And we did one on cancer and mental health here at St. George's, put together by myself, psychologists, pharmacists, professors of hemato-oncology as well, with some really good case studies. from diagnosis through to death, and how an integrated approach can really make an impact to patients. So it's just I can share these with you as needed as well. We heard a little bit about debriefing, and one thing I was mentioning to Dr. Zianda before we started was I have a sort of lead role in sort of innovative approaches to education, and increasingly it's become apparent that sort of high-performing individuals or organizations think a little bit more about pre-briefing, actually, so anticipatory thinking. So when you look across sports, when you look across other fields, when you have high-performing individuals and organizations, there is less of an emphasis placed on a debrief and more of an emphasis placed on a pre-brief. And that may be very different and difficult to do with an impending death, but I think Joe alluded to being part of that discussion before a patient died. And I think the reality is, when you look at the evidence base, and this is something, again, I can share with you, we published an article in the BMJ looking at how actually cognitively, how actually when you look at patient safety, and when you look at learning that clinicians derive from situations, it's interesting to see that the more you anticipate for scenarios arising, the more you mentally anticipate and go through all the combinations and permutations that may arise, the more clinicians feel more confident after, the less adverse psychological outcomes there are, and crucially, the more learning there is as well. So I'm the clinical director for simulation and clinical skills in our trust, and that's not so important. What is important is the way we think about an educational approach is about pre-briefing more than debriefing. So we have this little hourglass where actually, and we can think about clinical analogies to this. Before we go into a clinical scenario or a patient simulation or anything like that, we think about the scenario and we think about what we want to get out of it, and we pre-brief as a team. We pre-brief before the actual scenario, and actually the scenario or the clinical encounter, if you like, forms the sort of neck of that that hourglass, and then you have the debriefing or the feedback, which is only important enough in so much as it's also feeding forward and thinking about culture change. So I just wanted to mention that, and I can sort of think about sending across any resources that might be helpful, or certainly any discussions. And then finally, also just to highlight that some of us here at St George's were working with colleagues at Guy's and St Thomas's as well, and we actually edited the mental health and psychological and spiritual chapter of ESMO's first palliative care guideline, which is a very comprehensive and really holistic and really carefully written sort of document. So for those of you involved in oncology, I appreciate that's not everyone. There is a palliative care guideline that ESMO, so the European Society of Medical Oncology, I appreciate there's ESMO Africa coming up in a few months' time, but that's well worth a read. But again, it's taken a huge organization like that this long to recognize the importance of having a guideline around these aspects of palliative care. So, it's important to start somewhere, I guess, is the lesson. And finally, just a little plug, these are pictures of an actor playing a patient, but we've come up with some interesting, innovative simulation programs. I know we've had some trainees and consultants who have gone back to South Africa, actually, and they were talking about these things. This is a course that we run called CAMELS. You have to excuse the acronym, but it stands for Cancer, Mental Health and End of Life Simulation, where we've really thoughtfully put together a group of we did a learning needs analysis, held focus groups, what doctors, nurses, others found difficult to deal with in terms of conversations around death and dying, breaking bad news, conversations around mental health comorbidity. And we run this now very regularly at St George's. And we get doctors and nurses and others from all over London really coming for this course, and it gives them a bit more practice at these difficult sort of scenarios, the ability to shape practice, but also more importantly discuss things openly with colleagues, which makes a big difference. You can see the quote there from one of the med oncs, and again these are screenshots from a scenario. around a lady who's at the end of life, and you'll see, you know, she's dying there. That's her. It's an actor playing a patient, and again, her daughter there, and it's really about, you know, what makes a good death. And I think actually, education and scenarios like this have helped us no end to think about things like the spiritual aspects of care, thinking about sort of conversation guides, thinking about sort of, you know, working closely with palliative care, but also upskilling all of us, whether it be sort of, whether it be sort of hospital porters who know that they're sort of, you know, taking a patient, to a particular scan or to a particular clinical intervention, through to administrators, through to doctors and nurses, and through to others. And so it's just a little bit about the importance of sort of creative education. And I appreciate here that there's a lab there, all singing, all dancing, but just to say, you don't need that. You just need to know the sort of educational goals behind things. And we're lucky to have worked in a number of different environments and different sort of cultures with these different educational packages. And I guess just to finish up, this is something just about systems change, and it's just a model that I quite like in terms of sort of, you know, where you need to go to actually understand the genesis of changing something. So from the outset, exploring the problem, then defining it, and then redefining it. So defining it with data, and it's only at that point that you get the improved understanding of the problem, before then aiming to come up with a solution. And I guess, you know, one thing we're quite keen to do is test systems and to prototype systems. And however that looks, I think, you know, you're talking about systems change in South Africa. It's important to think about what that looks like for you. But again, you know, Joe gave the practical example of, you know, our oncologists who break bad news every sort of 15 minutes. And I think, again, systems that recognize that it needs a little bit of a time buffer, that as a start is a systems change that is probably well worth auditing, I think. So I think that's enough from me. I've probably overrun, and I'm going to stop sharing, and that is it from Joe and myself.
Okay, thank you very much. You touched on some very, very interesting points. And what I liked from Joe was the actual practical aspects of what you need to look out for when it comes to showing that you might not necessarily be coping, because we all go through it, but I don't think that we actually notice that all those changes could be something indicating that there's a problem. And also, you're correct when you talk about this needing to be systemic in terms of helping healthcare workers in dealing with this. I'd like to just pick up on two questions that we've received. The first one is going to be from Ngunza Okamba. And she says, or he says, sorry, please define post traumatic stress disorder and the cause for me. Is it not time related post trauma and with traumatic events? So they would like that question answered. I don't know who will want to go first. There is a second one, and the second question is from Rumbi Dawa. And the question says, they understand that we're talking from the end of palliative life care setting, but can you also just maybe mention a word on unexpected death scenarios and coping strategies?
Yeah, I think it's a good point, isn't it? It's thinking about when we know that there's a planned death. And I think when I was kindly invited to come and talk and think today, it was sort of obvious to me that we were going to have different scenarios. There's known deaths, ones that we're planning for that we can preempt, and more traumatic ones, and that can happen within cancer. But I'm conscious that you will be dealing with a whole breadth of death. So I think there's a sort of two-pronged approach, isn't there? Really, there's about having that upskilling and that training for the sorts of unexpected traumatic deaths that we might come across. So almost experience of being thrown into a completely unknown clinical scenario, and what that might look like, or at least having education where, like Asanga was alluding to, where more experienced clinicians are sharing those experiences, those learning points, and that's embedded within the teaching and training program, but also I think embedded in ongoing practice. As psychologists, we do that throughout our careers, that we have regular supervision and reflection and learning points, and I think that's something important. In terms of how we cope as human beings, I think it's knowing that actually if there is a sudden unexpected trauma, which essentially this is, we don't know how we're going to respond to that. It depends on the nature of the trauma that we're experiencing. It probably depends on our own coping and resources and resilience at the time. And I think it's important to do some debriefing afterwards, to support, as I said earlier, that kind of natural processing of what's happened and what you've experienced. Allow yourself to go with that. You may notice some trauma symptoms, so it wouldn't be a surprise to me if you're having repeated thoughts around that scenario, or you're having some nightmares, or you're thinking back to that. And, you know, I think that happened to me personally when I witnessed the death of my loved one, and that was planned and experienced, but it settled within a sort of 3 to 4 week period. So it's noticing if you are having, and I think Asanga's maybe going to talk a bit more about what we're looking at in terms of traumatic stress symptoms. You may experience some of that restlessness, that agitation, that difficulty concentrating, poor sleep, poor appetite, thinking back to the event. Certainly, as I've mentioned, I had some nightmares, but knowing that that's normal and expected, allowing yourself to think and talk and debrief about it with the people you feel safe to do that with, is going to facilitate that processing, and just knowing that's not an unusual reaction, but it's when we get to the point where that is persistent, and it's impacting on daily functioning, and those sorts of symptoms aren't resolving, that's when we need to take real heed and go, actually, okay, this for whatever reason hasn't resolved for me personally, and that's an indicator that I need to look for some more psychological and mental health support. So I hope that sort of answers the question, because you can only be prepared as you can be for something unexpected. I think it's knowing, A, that's going to happen, B, you're not going to know exactly how you're going to respond. You might cope wonderfully, but it's preempting, yeah, I might have some of these sorts of trauma symptoms. That's a normal part of the process. What do I look out for? And what's my window of knowing, actually, come 4 or 5 weeks, this is still persistent, I'm still struggling. That's the moment to say, I might need some extra help.
Yeah, and absolutely, Jo. Yeah, so in terms of sort of, post-traumatic stress and definitions, I think, Jo's sort of really spoken about the sort of approach to things, which is if it's having an impact on your functioning, then, you should really seek help with it. But actually, when you think about post-traumatic stress disorder as a group of symptoms, it's really highlighting that there's a delayed or protracted response. So that the onset of symptoms is often weeks to months after the event. So that's important, first of all. And then the second thing is, in terms of the symptoms that you might experience, typical features are around that of reliving the trauma. So whether that's around intrusive memories, whether it's about nightmares, flashbacks, dreams, that's one cluster of symptoms. And then there's, what it does to us. So there's the emotional numbness, the blunting, the fact that actually, you might be detached from things, and the anhedonia. So, loss of enjoyment in day-to-day things. So, if you're a huge sports fan and you don't care at all that the Springboks have just won the Rugby World Cup, aspects like that, that blunting, that detachment, that anhedonia. Or whether it means actually, you couldn't care less about what your children had done at school, whereas, you previously, did. So I think that's important. So it's the typical features are the sort of flashbacks and the reliving of the trauma, what it does to you as a person, and then symptoms around sort of hyperarousal. So startling, being hyper vigilant, almost being sort of, having that, acuity of your senses. I think the important things to also point out, though, is in terms of purity of diagnosis, what we know about mental health is actually, yes, diagnoses count. Of course they do. But there's a real possibility of anxiety and depression being interwoven with this. And in fact, they are comorbid. So you're not going to see PTSD without anxiety and depression. I think, suicidality is not infrequently associated with PTSD. And again, stepping back from the specific symptoms, the reality is these are things that have an impact on your functioning. So it's recognizing when that's happening, how it's impacting on your functioning day to day, and seeking help accordingly from that point of view. And again, recognizing that, if you've been through a traumatic experience, that actually hours or days after that, that's part of adjustment, and that's normal to have these things over a period of days. It is when it is prolonged and protracted for weeks and months that sort of sits in PTSD, if that makes sense.
No, it definitely does. There's a whole lot of interest from people. I'm trying to just make sure that we manage our time here. I think so. Some of the questions you've already spoken to, because somebody had wanted to know the difference between your PTSD. Let me just go down to the question. Yeah, he's just said that you've answered that question. Then somebody had then also wanted to say, how then maybe do you get your colleagues to be able to understand what you may be going through, so that they sort of understand what problems that you are dealing with in terms of this. So that one, I think it was asked by, okay, here we go. It was asked by Nilesh Patel. So she just wanted to ask, how do you get your colleagues to understand? There was also a comment, I think it was just a comment, the way they said that, you've talked about the celebratory parts of, the birth and all of that, and how then it becomes complicated when the two incidences, where there's the birth, but you also have an incidence of maternal death happening around the same time, which then also become, a bit complex to deal with. So they also had been saying, she did also ask, Sandile is talking about what Joe was talking about in terms of bringing your own past experiences, but balancing that with what is actually happening with the actual patient situation. I think that's just avoiding, I don't know what they call it, whether it's inference or or maybe you'll think of the better word. It's escaping me right now. How do you avoid that kind of thing when you are a practitioner? I think, let me stop there because I'm going to try and manage the time, but most of the questions here had been answered when you came through.
I think, can I just jump in on the last bit, and then I'm hoping Sanga's gonna be my aid memoir for the earlier questions. I think something that I was talking to Sanga about earlier when we were preparing for today is that you are going to bring your personal experiences. And I know that I lost my husband to stage 4 metastatic colon cancer, which is why I now work in oncology in the job that I do. And that has its pros and cons, as you might imagine. And I will bring my personal experiences to end-of-life experiences that I come across in my clinical setting. But I think what's really useful for me is for my personal coping. So I'll sort of break it up in 2 ways. So for my personal coping, I think about ways that I'm similar, ways the scenario is similar, or aspects that I identify with. But I also remind myself of what is different in this situation or this particular individual's circumstances. So it helps me connect enough to feel engaged and to be thinking about the sorts of things that may be relevant from my personal experience. But it's also helping support me in having a step back to go, this is different. This isn't the same experience, that there is enough difference here for me to feel grounded as a healthcare professional. to come into this scenario and think about it in this moment in its sort of uniqueness. So it's a real difficult balance to strike, because you will have knowledge from your personal experience that you want to bring. So it's how to do that, but in a way that you can also cope. So I think hold in mind that sense. I often ask myself in those scenarios, how is this similar and how is this different? And noticing those two can really enable me to do my job better, and can help me to care for myself in that moment and get that balance right. So I hope that answers that to some degree from my experience. In terms of the initial...
Yeah, I mean, you might have, sorry, I was just going to say, in terms of how you would sell it to colleagues, I mean, I guess I would say, you know, it's different depending on, different depending on your colleagues. And I think understanding your colleagues and their drivers is probably, I'm not the psychologist here, but understanding your colleagues and their drivers is probably a starting point. So, you know, what I do know is when we set up this service around patients, again, you know, we were having to influence commissioners and managers and others. And I think, you know, some were more interested in the stats, and there are compelling, if you're talking about the psychological well-being of doctors, there are compelling statistics around that. You know, if others are interested in workforce strategy, if others are just interested in a well-functioning team, there are different drivers for different people. You know, for some people, there were clear things around sort of, you know, cost-saving things when it comes to sort of patients and others. And so it's understanding what drivers there are for your colleagues. Now, you know, I will bow to the knowledge of my psychology colleague here, who probably understands people a bit better, but no, I don't know if there's anything else.
I think the only other thing to add would just be to start having small conversations. You know, do the modeling of checking in with your colleagues yourself, or starting, and in safe spaces with the right people, starting to say, actually, do you know what, that one really affected me today. I don't know how you found it, or if you had something similar. Or I think just having those small, gentle conversations and starting to show that to other colleagues, hopefully gives it. And I think certainly as seniors, as leaders, that's really important to be modeling that. But it's different depending on the team cultures and strategies, and sometimes that's a challenge, and acknowledging that challenge, I would say.
And just to say, actually, so Schwartz rounds, when you look at these movements, actually there's often a critical mass, because, you know, whoever came up with that question, I think it was Dr. Patel, if you're thinking it, lots of people are thinking it. And, you know, I mean, you know, in our team, cancer and mental health, you know, I try and speak to non-medics about it, and they say, well, it makes total sense to bring those two things together, but why has it not happened till now? And so actually, Dr. Patel, you know, if you're thinking it, others are thinking it, and things like Schwartz rounds, you know, really having organizations where there's senior role modeling that does a good job of destigmatizing things and normalizing things makes a big difference, I think, as well.
Okay, no, thanks. I've seen that within our comments there is also just where people are touching on the unrealistic expectations that we sometimes give when it comes to prognosis. So I think that's just for noting, to say, you know, it's important that we are upfront when it comes to prognosis, so that the family does have time, you know, to actually process and you know, plan and discuss. I think at this point it's important that I mention that SADC does have a pro bono line. It's 0800 21 21 21. It is pro bono, it is toll free. So if you do happen to find yourself, you know, in that situation and you don't have, you know, access, please do use the telephonic counseling service. Once again, the number is 0800 21 21 21. Thank you so much, Dr. Sanga and Joe. I think that was very insightful, and you know, you've practicalized it, I think, for us as clinicians to see, you know, what are those signs that we are not coping, but also to try and give us an approach as to how we can deal with it, not only for ourselves, but within our teams, you know, that we have in the workplace, to make sure that we are all coping better with this, or not just at the workplace, but also ourselves, also to make sure that, you know, at a social level, we're also able to function. Thank you very much. I think that was a very valuable input. We very much appreciate it. At this stage, colleagues, I would like to take time to introduce our next speaker. Our next speaker is going to be Ms. Siba Njoba, who's going to be discussing estate planning, which is a topic of particular importance as well, as it is often neglected by medical doctors. Ms. Njoba is a professional financial planner and holds a BCom degree in economics and postgraduate diploma in financial planning. Her key areas of expertise are retirement planning, investment planning, risk planning, and employment benefits consulting services to corporate, institutional, and retail individuals alike. So that is Ms. Njoba, who's now going to take us through to the last talk of the evening. Siba.
Yes, I'm here, Dr.
Hi,
Zanele.
I'm glad you're here. It's Siba. Maybe you can start preparing your slides. And unfortunately for you, Siba, you've got the unenviable task of talking about estate and life planning. We tend to run away from the likes of you because all we think about is policies and we think it's just, unnecessary, not realizing until the critical moment what it would have meant had we actually put thought into our estate planning and taken the few, moments to sit down with somebody that would actually navigate us through and ensure that we actually have put our family in the best position when we are gone. So yes, Siba, I'm interested in your talk, and I do know that it tends to be one of those that we run away from. So over to you, Siba.
Thank you so much, Dr. Zanele. So good evening, everybody. Gosh, it's freezing in Johannesburg this evening. I hope you're all warm wherever you're joining us from. And as introduced, my name is Siba Njoba. I am representing a company called Imvelo Wealth Solutions, which I co-founded in 2019. We got our license to start operating our practice. Okay. So there's my business partner there. Just a little bit of a brief background on our business, and I will just quickly run through our holistic business offering. As a business, we do a covering for individuals. We will do your retirement planning, the investment planning, risk planning, estate planning, which we will be delving into in detail today. We also do financial coaching as well as business assurance. And then for your employers, we also do what is called reviewing employee benefits. So you'll find an organization, they'll say, Siba, we need you to help us package our employee benefits that will include the pension fund and the group risk and all of those kind of benefits. We also do what is called retirement benefit counseling, as well as business assurance covers. We do workshops, seminars, one-on-one consultations with employees. So even if you are a doctor and you have a practice and you want us to have a one-on-one consultation with your employees, you're more than welcome to give us a shot and we will assist where we can. Very importantly, our practice is what is called an independent practice. We have an array of service providers that we've partnered with to be able to assist you with all your various financial planning needs. And here now is a list of all our business partners or service providers who we do business with. So if you come and you say, Siba, I need assistance, I'm retiring, or I need life cover, or whatever the need is, we've got this array of providers that we can tap into to be able to assist you. Now, I'm going to jump straight into the agenda of the evening. Legally or by law, anyone who's over the age of 16 years can do a will. That's free. You can go to the banks, you can contact an attorney or a lawyer who can help you draw up your will, or you can come to a company such as ours at Imvelo Wealth. We will be able to assist you in drawing up your will. Some important things that I would just like to highlight with regards to setting up your will, that is, you need to be able to appoint an executor. Now, this is somebody who is going to be taking over your financial affairs in the event of death, right? And some important things about the executor is that this is someone who's going to charge about 3.99% of your estate, and with the VAT, it's 4.25% of the value of your estate. So it's very important that when you are doing a consultation for estate planning, you understand which of your assets will form part of your estate upon death and what won't. What will you be paying the executor to wind up and what you won't be paying them for. So it's very important that as you sit and understand what you have in your assets and what will form part of the estate, and how also, what are the strategies that we can use to help you lower your estate duty? Because if you have an investment at Allan Gray, for example, or any other provider, you need to understand, will this form part of my estate or will it not? But we will get into some of the technical issues about your estate planning as I delve into all of this, right? So as I was explaining, this person called this executor. Now, if I don't do my will, right? If I don't do a will, what does it mean? It means that the executor will be appointed by my family members or whoever I leave behind. They will then take it upon themselves to go to the master and they will have a meeting and say, we will appoint whoever that will be appointed by the family to represent you and your wishes. And that's a very dangerous position to find yourself in, because had you done a will, you will say, in my will, I am appointing this firm, or I'm appointing this individual to take care of my financial decisions and make sure my estate is wound up in the terms of which I would want it to be wound up, right? So now you give away that right to have a voice the minute you do not have a will. The other thing I wanted to note about having a will is that in as much as you need to be 16 years of age to do a will, you are able to also note that you need to be mentally capable. You know, you need to be in the right state of mind to be able to do your will. So, I see we're getting a number of questions that are coming in. We'll deal with those as we go through the presentation. Going back to this discussion about the will, if you don't leave this will, right? As I said, your family members or your heirs will decide now who will be nominated at the Masters of the High Court. And also, by not appointing an executor and by not having a will, you delay the process of winding up your estate. The other thing that is important is that the minute someone passes away, obviously the death is registered and so forth. But the impact of the death is that all their assets and everything they own is going to be frozen. And the process of winding up an estate can take months, especially, and years even, especially if there's no liquidity in an estate. So when I talk about liquidity in an estate, I'm talking the executor will end up having to sell some of your assets if they find that there's a situation where there's not enough money to pay your creditors, or there's no money to pay some of the costs that are incurred upon a death. Some of those costs will be funeral costs. Some of those costs will be making sure that there's enough money to pay your creditors. That's very important, because now your estate can't be wound up fully if there's still creditors that have a valid claim against one's estate. Now, the other question that one could ask is, what happens to the children of the deceased, right? So if one parent dies, then naturally then the other parent will be the legal guardian and they will continue parenting the child. If in a case where one is a single parent or both parents unfortunately die in an event like a car accident or something of that nature, then the children will have to be allocated to a legal guardian. So you need to be able to make provision for such things on your will, to say, if my husband and I both die in a car accident simultaneously, what happens to the children? Do you want them to live with your mother? Do you want them to live with your sister, your brother? So you need to be able to make provision for such things on your will. And the other risk is that there's monies, for example, that should pay out to your minor children. So say, for example, if there is money in a pension fund, for example, if you've been working for an organization and you've got a bit of retirement fund savings, what happens with those funds? There's various legislation governing retirement funds that will kick in upon death. So say, for example, there's a specific piece of legislation called Section 37C of the Pension Funds Act. Now, what happens there is that the trustees of that particular retirement fund, they will sit and look at your nomination form. Who have you elected to be your beneficiaries or your nominated beneficiaries for any amount that is coming from your retirement funds? So the trustees will sit and have a look. and decide how to disperse those funds. So it's very important that you understand as an individual, what do I have in terms of my financial life, and how are these various aspects of my financial life affected if I am to pass away. Going back to the children, right? If your children are still minors, that is under the age of 18, you can also set up what is called a special trust for them, and say, and on you will make provision for a special trust to be set up, and that trust then, normally when you're setting up a testamentary trust of that nature, you will also note that this money must make provision for the children's education, their well-being, and any extramural activities and anything pertaining to their upbringing in your absence. So it's very important to note that if you do not make a will, then you leave these key decisions to other people. And I think that is such a big risk. And very importantly, if there's a child or children that are minors, their funds, or because now the important thing, let me just take a step back. Because now, if you have minor children, lump sum monies can't be paid out to these minor children because they can't make financial decisions for themselves. So your lump sum money, even if you have a life cover, for example, and on that life cover, you've nominated your 5-year-old to be a beneficiary, that money cannot pay out to a 5-year-old. However, provision can be made through what is called a guardian fund, that money pays out to whoever the legal guardian is going to be if you are no longer there. So I think these are quite important questions that you sit and address as you think about what you want your estate to look like, or how your affairs should be run in the event of your untimely death. Now, statistics say that less than 15% of South Africans have a will when they pass away. Do you see that this is now such a big worry? What is the reason? I think we need to homework ourselves and ask ourselves, why are we not having our wills set up? The other interesting part, important part actually, that kicks in the event of you passing without a will, right, is that the law of interstate succession will kick in terms of how the government now is going to deal with your financial affairs. Because if you fail to do your will, then you are giving the authority or the master of the court or the government to then make these crucial decisions on your behalf. So if you pass away and you are survived by a spouse and children, then your spouse will receive the greater share of 250,000 Rand worth of what is the monetary value in your estate, or they will get the greater of what is called the child share. How that works is it just basically says, if there's a claim at hand, what is the first question that's going to be asked? What's the value of this estate? If it's less than 250,000, it doesn't have to go through the formal court. However, we will use this rule that says, if we look at the value of the estate, and let's say there's a wife and 3 children, and the value of the estate is 2 million, for the purposes of distributing this amount of money, we're going to then say the wife, she's entitled to 250,000. However, because there's 2 million available and there's 4 of them, all of them would be entitled to 500,000. So she will then get the 500,000 because that's the greater of the 250,000. I hope I'm clear on that point. So it's either she's going to get minimum 250,000, or if there's more money in the estate, then your wife will get the greater of the 250,000, which will equate the child's share. So the estate basically will be divided by 4. Another thing I'd like to then clarify is that if you die without a will and then there's no one who's there to say I'm a family, then and there's absolutely no one who can inherit from the deceased estate in terms of the Wills Act or in terms of the Interstate Succession Act, then you will forfeit all your assets. Everything you own will go to the state. And you've got a 30-year period where before this money ultimately becomes state property, there's a 30-year time frame where this money will be put in the guardian fund, and in that 30-year time frame, somebody has to come and say, I'm family, or this is money I'm entitled to be able to claim from because it's my aunt's money or it's my mom's money, whatever the case is. And how is it that people, what is the test that is used for you to show or that you are family, or the degree of relation, actually, which is the legal technical way of describing it. We look at this table here that I have, and it's called the table of consanguinity. So if the individual, you can see that it's written person, if that person dies and there's no children right underneath him, and then there obviously won't be any great-grandchildren, then we look at the next line, which is the parents. So if the deceased has no children, we'll look, do they have parents? If they are parents, if maybe the parents both have passed away, we'll look, do they have brothers or sisters? Are there any nephews or nieces, great nephews, nieces? And if there's none of that in line one, you will then go and look at the grandparents. Are there any, and under that, if the grandparents have passed away, we'll check, are there any uncles or aunts, first cousins, and so forth. If we can't at any point of searching for your family within those degrees of consanguinity or degrees of relationship, then after a 30-year time period, the money you have, you will forfeit to the state. Now, the importance of estate planning. I really like life cover. And as Dr. Bikisha mentioned earlier, we always think of life cover as this grudge purchase. All advisors will tell you about the importance of having life cover, but I really think life cover is such a fantastic estate planning tool, and I will talk more about life cover in my next slide. But I think if you have your estate planning in order, you will protect your business interests. For example, if you are a GP here in the chat this evening, and you've got business partners who are other doctors who are specialists, it's very important for you to have some form of a succession plan to say, if this specialist surgeon, for example, is not in the practice anymore, how is the practice going to run? Because there's the risk of financial loss. There's the risk of the reputation for the practice. All of those things can be mitigated if you have a proper estate plan or a succession plan for your business and your practice. Life cover is also a very important tool for wealth transfer. Over and above that, your estate plan must also cover all the components that need to be addressed pertaining to how you can transfer wealth, the use of trusts, making sure your will is valid, also making sure that the estate plan is updated and reviewed annually. It's very important. Also, over and above that, understanding that for any estate to be viable, you need to make sure that it covers all the estate costs, which range from the executor's fees, funeral costs, all the costs pertaining to the actual process of winding up that estate needs to be covered, and make sure that your estate plan is agile enough to make sure that your estate will be wound up quickly in the event of your death. And as I was saying, life cover again is such an important estate planning tool. Say for example, you've got this life cover that you've got. You can say to the bank, you're going to use your life cover instead of what is called credit life cover, which is offered by the bank. So the credit life cover really just says if you have a bond or if you have a vehicle or any credit, for example, even a credit card, you can take up credit called credit life cover. So you can use your own life cover. You can say, I'm already paying this premium for life cover, and you can use that to cover your bond or your mortgage upon your death. You can use your life cover to say, all right, I'm going to take up a life cover and make sure that my children will be taken care of in the event of my death, and use that as a way of transferring wealth. And also that life cover is great because it can create liquidity and cover your personal debts, that being credit cards, loans, or any other form of debt. You can always use that life cover to make sure that it covers all your debts. And again, going back to the example that I used about business assurance, it's very important that you know if I don't wake up tomorrow, how is the practice going to, what is the process we're going to have for business continuity? So I think those are some of the very important things that you need to consider as you look at your estate planning. And there are our contact details for our business. If there are any questions, you're more than welcome to pop me an email, and I will respond, or you can call the office and set up an appointment with us.
Thank you very much, Siba, for that. There is a question here by O Diego. They're asking if you can nominate your fiance or any friend as your pension beneficiary.
Yes, there isn't any rules that say you can't nominate a specific individual to be a beneficiary. Therefore, the answer is yes. You can, for your pension fund, you can nominate anyone. But now they also might have to show, for example, in specific cases, if the fiance can say she was financially dependent on him monthly for maintenance of how much ever the amount, then that amount this individual can come and use even against your estate to say, Siba used to give me 10,000 every month. So then she can come and have a valid claim against my estate for that amount monthly.
Okay. No, thank you very much. I think this is going to be the last that I'm going to take from the questions because we are a little bit over the time we had scheduled. So these are the last two I'm going to give you, Siba. So the one says, what are some of the most common mistakes that you see when people set up wills and estates? And the second is going to be, when married in community of property, do you have to do a joint will?
Okay, great. All right, I'll tackle both of the questions. The first one was talking to
Common
Am I just
mistakes when doing
common mistakes?
estate
Okay, yes,
will.
great. So common mistakes, for example, is that if you're husband and wife, and it's very important that your wife does not witness the same will, because then she or the children must not witness if they are going to be beneficiaries in that will. So the rule says, if you're going to be a beneficiary in the will, don't sign the will. You could end up not getting the benefits that you could have got, because then that invalidates the will. So you want to make sure that the will is done in accordance such that you don't end up having unintended consequences, like, for example, not end up not getting the benefits that you would have gotten, especially if you're a beneficiary and you sign the will. So those are some of the little things. I mean, we've seen cases where a case where it was
I think Siba is having a little bit of a technical issue there. But we did capture the last part where she indicated that you should not be signing on the will when you are going to be a beneficiary. So I think we caught that part. Siba, I don't know if you're able to get back. Okay, it looks like we've lost Ziba over there. The last question that they had asked was about being married in community of property, whether or not you do have to do a joint will. I know that that is not necessary. You don't have to do that, but it does make sense to do estate planning so that you both understand what are the resources and how to structure it in a proper way so that you've got an idea of what your common issues are. And I think also if Siba was here, she would also kindly remind us that in the new South African setting, you are now considered to be married once lobola has been paid for those of us that are African. As long as there's witnesses to a lobola and some side of acknowledgement happened, you are considered to be married, and that marriage is considered to be in community of property. So I think that's just important to take note with us, that unless you actually get into an antenuptial, your marriage then de facto becomes a community of property, but we also are recognizing our traditional practices, meaning that once the bill has been paid, you are essentially able to claim that you've been espoused. Colleagues, I see that we're not getting Siba back. This has been a very interesting evening, and I'm sorry that we've taken you a little bit of a time. It was, quite insightful, and it helped us, I think, understand how to deal with, the mental load that we carry as health professionals day in and day out when we deal with these difficult topics of death, not only in in our own personal lives, but also those of patients on a daily basis, and also those who also live and work in palliative care medicine, which in itself can also be taxing. We've learned some coping strategies and how to recognize when it becomes pathological and might actually need some sort of intervention. And we've also been given some very practical, steps to take so that at the end of the day, we're able to try and center ourselves and take a little bit of, self-care and give ourselves some mental space. And that should be something that we're helping. And we're also given some key tools to actually show that this might be an indication that you are not coping. I'd like to thank all of you guys that have been with us, and I'd like to thank, the panel. You've been very informative, and I hope that as practitioners, we're kind to each other and we make sure that we attend to our mental health. I'd like to just acknowledge our chairperson, Dr. Mzukwa, who is in this webinar. It would be very wrong for me not to acknowledge him. I don't know if you just want to say some parting words, Dr. Mzukwa.
Dr. Bigichai dropped off.
Oh, okay. All right. No, thank you very much, colleagues. I'll call it a night, and please do join us again as summer. We will have another kind of informative presentation. Thank you very much, colleagues.